Hi everyone, welcome to my channel. We are going to start one thing of medicine, general medicine subject. It is rheumatology of part of. So as we have completed, guys, we have completed the uh, respiratory in the past video, and we have moved further for the rheumatology. So guys, in this we will start for rheumatic disease, rheumatic field, which is a very large topic in the medicine. So local disease of rheumatology, first we will classify and then we explain on the, one by one of each disease and its investigation, treatment, and and its major important factor, clinical features. So guys, first our priority is to intra-articular and versus extra-articular pathology. So involves synovium, hyaline cartilage, intra-articular joint capsule, rheumatological problem, diffuse and deep-seated pain, pain on active and passive movement, swelling, crepitus, deformity is seen. These all are features of intra-articular. What is about extra-articular? So involves ligaments and tendons, fascia, muscle, okay. Orthopedic problem, localized superficial pain, pain on active movement, localized swelling away from the joint. These all are the part of extra articular. Articular pathology, synovitis, and versus articular cartilage involvement. So guys, seen in synovitis, articular cartilage involvement. Seen in rheumatic arthritis, inflammatory synovial hypertrophy, venous, and bone erosion. Here, associated features takes place. But in the articular cartilage involved, osteoarthritis, non-inflammatory, loss of joint space, osteophytes, subchondral sclerosis. Third step in synovitis. Only synovitis is seen in RA, SLE, rheumatoid arthritis, SLE like arthritis, Sjogren, polymyositis, dermatomyositis. What is RA? Rheumatoid arthritis is erosion seen in juxta-articular osteopenia, deformity due to erosion. Here, erosion will be takes place in the bones. So, okay. So, SLE and like arthritis, erosion not seen. No erosive deformity due to laxity, also called as a Jacob's arthropathy. Okay. So, Jacob's arthropathy also seen in the acute rheumatic fever and erosion, non-erosive arthritis. So, what is the erosive and non-erosive arthritis? Rheumatic arthritis, psoriatic arthritis, chronic crystal. Then I will focus on this. Go to revision now. Rheumatic arthritis, psoriatic arthritis, chronic crystal arthritis. In that, MSUM is more affected than CPPD. Multicentric reticulohistiocytosis. These all are erosive arthritis. Now, guys, I am talking about the non-erosive arthritis, SLE and SLE-like arthritis, acute rheumatic fever, acute crystal arthritis, relapsing polychondritis, RPSC. These all are non-erosive arthritis. Now, if erosive positive in SLE, the Rupus syndrome, RA plus SLE overlap. Magic is a syndrome or magic is a trick for remember mouth and genital ulcer, Behçet's disease plus inflammatory cartilage RPC. Means mouth and genital M और IC का मतलब हो जाएगा inflammation and cartilage. So we move further. So spondyloarthritis, synovitis plus entheritis plus dactylitis ये है इसका combination. Axial predominant SPA तो ankylosing spondylitis bilateral scoliosis. Peripheral predominant SPA. Here psoriatic and reactive two types होते हैं peripheral. Symmetrical polyarthritis more than 5 joints. Asymmetrical oligoarthritis 2 to 4. ठीक है. Crystal arthropathy, synovitis due to crystals, monosodium urate, monohydrate crystals. ये है MS वहाँ पे आपने देखा था ना, we have seen that this is, so what is the full form of this MSUM? So MSUM stands for the monourate monohydrate crystal, and CPPD, calcium pyrophosphate dihydrate crystal. So for MSUM, gout, first MTP, metatarsophalangeal, more than knee joint. Here, the MTP is more commonly affected as compared to knee joint. But in a CPPD pseudo-gout, knee joint will be affected only. So remember this great difference between the pseudo-gout and gout. Note symmetrical polyarthritis of small joint of upper limb. Acute, chronic. Less than 6 weeks, so acute. More than 6 weeks, chronic. So acute, what is the acute? Acute reveals that the post-viral parvovirus B19, undifferentiated arthritis. So these are all are acute form. In acute monoarthritis, knee septic arthritis more than CPPD, calcium pyrophosphate dihydrate crystals, pseudogout. Okay. First MTP, first MTP. So MSUM will be affected in this. Chronic में rheumatic arthritis, SLE like arthritis, pseudoarthritis, asymmetric oligoarthritis, peripheral SPA, reactive arthritis, psoriatic arthritis. Now I'm talking, guys. This is very important topic. I will hear few. I want to share. This is a very important topic. Rheumatoid arthritis. That is one of the best topic ever I have seen. My favorite topic in the medicine. If somebody asks me, so I will tell that my favorite topic is rheumatic arthritis. Most common chronic inflammatory multi-system autoimmune connective tissue disease. Here 40 to 60 is a peak range. Female male ratio. So male is 3 ratio 1. Male ratio. Female male ratio. So female is by 3 and male is 1. Note second most connective disorder, Sjogren's syndrome. Most common arthritis, osteoarthritis. Etiology, what is the etiology of this disease? So genetic factor will be first priority. What genetic? HLA-DR1, QKRAA amino acid motif, also called as a share epitope. HLA-DR1 13 protective. These all are protective. HLA associated factor. Okay. In genetic factors I am talking about. Non-HLA associated factor with PADI 4, peptidine, arginine, diaminase 4. Arginine, normal amino acid, you know that. By enzyme PADI is converted into citrulline, abnormal amino acid. Okay, so PADI is one of the non-HLA associated factor. PTPN22. This also another enzyme. Okay, guys. Or environmental factor like a smoking, strongest risk factor associated with a bad prognosis, increased risk of interstitial lung disease in RA, increased experience of party 4 in airway, infection, chronic periodontitis caused by polypyromonas gingivalis. Okay, so teeth also affected in this infection. Alcohol is also mild protective. Okay, and OCP are protective environmentally. But it doesn't mean that you start drinking alcohol and um, from now, because it is helping from the rheumatoid arthritis. Don't think that thing, because alcohol can cause many different kind of another disease that damage your liver. So it is requesting to all you that to restrict alcohol, not to drink alcohol, because it will be dangerous and hazardous for your life. So, note smoking is associated with the interstitial lung disease is seen. Desquamative interstitial pneumonia, Langerhans cell histiocytosis, interstitial lung in rheumatic arthritis, respiratory bronchiolitis associated with the interstitial lung. What is pathogenicity? Environmental and genetic factor, abnormal protein modification, citrullination. Abnormal protein present in a APC, Langerhans cells of dendritic cells, T cells to T cells, so secondary activation of B cells and neutrophils, migration to joint. Synovial hypertrophy, type ABA is more than type B, synoviocytes. Pannus formation takes place, both erosion will be okay. What are the autoimmune of the RA? So you know that RA is a very important and autoimmune bimari or autoimmune disease. So guys, anti-CCP, anti-citrulline polypeptide, mutated citrulated vermintine. This is a antibody. So what is the feature of this antibody? Seen in 80 to 90% cases of RA, specific 95% of RA, best marker for preclinical infection, increased risk of extra articular feature. Anti-CR CAR-P associated with the penidromic rheumatism, anti-PADI4 antibody, rheumatic factor I am told about you. So IgM directed against FC portion of IgG, increased titer away also with increased activity. Specificity 75% से 80%. Also positive in a Sjogren, cryoglobulinemia type 2 and type 3, polyarticular GM. So note one thing, marker for relapse of RA, ESR and CRP. So these are the relapse in RA. Anti-CCP and RF hold no value. So guys, what are the clinical features now? Listen very carefully. Articular manifestation, duration more than 6 weeks. Bilateral symmetrical, intra-articular, inflammatory, indicated by morning stiffness and for more than 45 minutes. Peripheral small joint and upper limb polyarthritis. Disease starts at the distal radioulnar joint. Radius and ulnar joint from the distal part of the, not a proximal part. Joint involves spared rheumatoid arthritis. Note DIP joint. dist- So DIP joint is involved in psoriatic arthritis, erosion arthritis, wrist, MCP, DIP, PIP. ठीक है. तो ऑस्टियोआर्थराइटिस रिस्ट एंड एमसीपी, ठीक है. मेटाकार्पल joint, distal interphalanges, proximal interphalanges, MCP, DIP, ये सब these all are juvenile arthritis, multicentric reticulohistiocytosis. So guys, first you know that the difference between joint involved joint non, which involve MCP, wrist, PIP, C spine, cervical spine. These all are involved in RA. Not involved DIP, first CMC, first MTP, metatarsalophalangeal, ठीक है, thoracocolumnar and sacral spine. These all are spared. These all are involved. MCP, wrist, PIP, C spine, proximal interphalangeal, ठीक है, metatarsal phalangeal. It is all not involved. Proximal involved. This we have to remember this. So guys, one of the best table which detect that the RA and its features. So carefully listen this all. So juvenile idiopathic arthritis, multicentric reticulohistiocytosis, progression of the disease. Okay. Then progression of the disease. I will continue focus on this. I have to focus on this. You can know this. There. Now, guys, one is a zigzag deformity. Zigzag deformity like this hand. Hand will be like this. Patient hand will be like this. Radial ill deviation of the wrist plus ulnar deviation of MCP, metacarpal phalangeal. So first is a deformity, this zigzag deformity. Second is a subluxation of MCP joint, metacarpophalangeal. One is a piano key of styloid bone. So rupture of ulnar collateral ligament. One is another, that is a Hitchinger thumb deformity. Here the thumb shape will be like Hitchinger, abduction plus hyperextension of the thumb. You can see the angle between the one thumb is usually straight, 90. So abduction, so on opposite direction going a thumb and hyperextension of the thumb. So it is a, these all are reversible characteristics. Now I am going to discuss about the irreversible. If it is takes place, so cannot be go into its original origin position. So be aware for this irreversible thing. One is a botonier deformity, flexion of PIP plus hyperextension of DIP. One button botonier means you can see this deformity. Here you can see the focus I will focus on this image. The you can okay. You can see this boutonniere like deformity in this. So be aware from this irreversible causes. And swan neck deformity, I will also talk about the swan neck deformity. Swan neck deformity is a hyperextension of PIP and flexion of the IP. These all are very critical thing, but you have to remember. You can see that hyperextension of proximal interphalangeal plus flexion of the distal interphalangeal. So this can result into this type of deformity in this person or in this patient. One is a opera glass hand, arthritis multilens. This will be takes place. So other joint involved in deformity is TM joint, C1, C2 joint, odontoid process erosion, cricoarytenoid change in voice, fifth MTP, metatarsal phalangeal, most common involved, pes planus, forefoot parus, ankle valgus. These all are deformity. Extra articular manifestation will be discussed now. One is a rheumatoid nodule. What is rheumatoid? Here you can see clearly in the diagram. I will focus on the first. What is rheumatic nodule? So our aim is to understand, not to go. Rheumatic nodule is extra articular manifestation. 40% cases, 20% of with 1 year of onset. Most common site is oligrenone tender nodules associated with the smokers and anti-citrulline CCP मतलब citrulline तो प्रोटीन है एंटी and rheumatic factor positive early onset long duration RA granulomatous resection of type 4 hypersensitivity size decrease on treatment. So rheumatic nodule you can see clearly in this tabulated form of the extraarticular manifestation. Now another will be neuroocular manifestation. We have the CNS, PNS, central nervous system, peripheral nervous system, and ocular. In CNS, no brain parenchyma involved. In C1, C2, myopathy takes place. Entrapment, neuropathy will be also takes place. So for PNS, RA-related small fibers, peripheral neuropathy. In ocular, most common dry eye, keratoconjunctivitis sicca. Remember, this is a very important point for as I've given in the red letter. So we have to focus very much on this. You can see that the dry eye or keratoconjunctivitis sicca. Episcleritis is more than scleritis. Ocular thinning of sclera, scleromalacia perforans. Uveitis is not a feature. Remember, it is very important to note for you that uveitis is not a feature of this. Okay, it is a scleritis. Episcleritis is more than scleritis. So, rheumatoid arthritis is only for episcleritis, not for any other thing. We will continue further. Hematological manifestation. You can see this structure, large granular lymphocytes, LGL. Here, the large granulocytes will be seen in this. So, most common is anemia of chronic disease. Normal WBC count in SLE, leukopenia, and lymphopenia. Thrombocytosis, rapid progression of anemia, warm IgG, AIHA, increased risk of diffuse large B cell lymphoma, LGL leukemia. These all are the feature of the hematological manifestation of the rheumatic disease. Now, Felty's syndrome, seen later in the disease, nodules, deformities, positive, RF negative, RF positive, HLA DRB1 4 positive. Antibody against citrulline histones positive. Features of RA and neutropenia plus splenomegaly. These are the features. Now, guys, I am discuss about the lung manifestation. What will be the lung manifestation takes place in the rheumatic arthritis? So, guys, what are the lung? First, I will honeycomb appearance in this upper side of the parenchyma. You can easily see that मधुमक्खी का छत्ता या honeycomb appearance. जैसा it will be visible in this lung manifestation of the rheumatic patient. Now, the pleuritis plus exudative effusion, low sugar, low pH, interstitial lung disease, usually interstitial pneumonia, that usually interstitial pneumonia will be seen in this fibrosis, traction bronchiectasis, honeycombing, loss of lung architecture, cyst in the lung, Kaplan syndrome is another cause. RA plus nodules in lung, cold workers, pneumoconiosis, seen in active synovitis plus rheumatic factor probability. Now, guys, after lung, we have focus on the CVS manifestation. Most common cause of death in RA is accelerated atherosclerosis. Most common presentation is pericarditis. So, with of tamponade. So pericarditis also a cardiac tamponade, that will be a second presentation. Most common valvular disease is mitral regurgitation. Okay. I'm talking about the renal manifestation. Most common manifestation is secondary amyloidosis. What is job of the GIT? GIT vasculitis is another type. ठीक है? Vasculitis in RA, immune complex mediated small vessel vasculitis, most common lesion purpura. Histological leukocytoclastic vasculitis, dangerous form, multiple vessel involvement, gangrene. GI vasculitis and mononeuritis multiplex. These all are rituximab for the use for the treatment. As you know that vasculitis is a one other form, another type of disease. Now, what are the other manifestation will be takes place in the rheumatology? So other manifestation, so flexion tender tendinosynovitis, bursitis, hypoaldosteronism, osteoporosis, pyeloderma, gangrenosum. ये सारे दूसरे हैं, but we have to focus on the note the interstitial lung disease and vasculitis in RA are more common in males. So as we further move presentation of the rheumatic disease or rheumatic arthritis. So preclinical rheumatic arthritis, genetic and environmental risk factor positive. Auto antibody of RA positive symptoms without clinical evidence of rheumatic arthritis. Clinical symptoms of small joint of polyarthritis most common. Symptoms pain and inflammation due to SLE, SLE-like illness, no erosion. Psoriatic arthritis, no DIP involvement. CPPD, pseudo-RA, waxing and waning, no erosion. Palindromic rheumatism, intensely painful brief episode of monoarticular arthritis. Mimics gout, antibody involved, anti-CRC, CARP. What is the early feature that come with the rheumatic disease? The patient, what the early feature will be present with this disease known as a rheumatic disease? So, guys, it is very important for doctor or a clinician for to identify the disease and its importance. So I will like to share one thing is early morning stiffness of small joint plus normal examination and X-ray finding. Then I will suspect viral arthritis or parvovirus. If the symptoms persist more than 6 weeks, okay. If symptoms were less than 6 weeks, so I will diagnose I was right. Yeah, it is a viral, so viral. But if symptoms not cure, if symptoms persist more than 6 weeks, suspect and differentiate arthritis, remission in one third cases, persistent of UA or progression to other disease in one third cases, evolve into RA in one third cases. So we will divide one third cases, evolve RA, progression of upper arthritis or remission one third cases will be determined. ठीक है? Scoring factor determining undifferentiated arthritis involving into rheumatoid age, sex, joint distribution, morning stiffness, tender and swallow joint, markers CRP, RF, and DCC. Score more than 8, treat as a RA. If these all are scoring, and if it is score is more than 8, then it will be RA. Now, guys, I am describe the management of rheumatic disease. So it is very important for a clinician to do a treatment of any disease. There is a DMRDs, biological agents, and small molecules. Three types of the management are available for the treatment of the rheumatic disease. So our aim is to first is the drug of choice, that is a methotrexate. Okay, DMRDs, disease modifying rheumatic arthritis drugs. So DMRD, so methotrexate, leflunomide, sulfasalazine, hydrochloroquine, HCQ. These all are DMRDs. Biological agents like TNF alpha, etanercept, anti-CD20, rituximab, anti-interleukin 1, anakinra, anti-interleukin 6 tocilizumab, CTLA4 या FC, IgG fusion molecule abatacept. What are the small molecules? JAK1, yeah, 2, 1 JAK1 slash 3 inhibitor, tofacitinib, JAK1 inhibitors. So it is a bursitinib. These all are starting from the methotrexate. For this methotrexate, very important for the 5 gram weekly dose for up to 25 week, starting from 5 mg weekly dose of may go up to 25 weekly dose. CBC LFT is supposed to be monitored. Side effect. What is the side effect of methotrexate? Mucositis, dose-dependent bone marrow suppression, hypersensitivity pneumocystis, increased size of nodules in 10% cases, remission assessment of Boolean score, clinical assessment less than 1, tender joint less than 1, swollen joint less than 1, CRP less than 1 mg per dl. So these are the remission assessment of Boolean score for the rheumatic. So it is supposed to be less than 1. Another no remission combination therapy used: methotrexate plus sulfasalazine plus hydrochloroquine, methotrexate plus TNF alpha inhibitors, or methotrexate plus JAK inhibitors. Now we move further for another topic, that is a rheumatology of SLE. So guys, I hope you have understand this big topic of rheumatic arthritis and its now the SLE, systemic lupus erythematosus, will be continued in this. So be aware, be ready for the another phase of the disease. So I will continue this video. So systemic lupus erythematosus general features fail female ratio 9:1. Male in then severe disease. If male takes place, so very severe disease. Family history, yes, there will be family history. Renal involvement in SLE, adult SLE, childhood SLE, postmenopausal SLE. So 40% are renal involvement, adult SLE. Childhood SLE is 100% renal involvement, like that. And postmenopausal is mild disease of renal sparing. Most common cause of death, first 5 years, infection or lupus nephritis. After 5 years, acceleration, atherosclerotic or MI. Risk factor, genetic factors, non-HLA or HLA. Non-HLA, human HLA, human leukocyte antigen. So CQ1, C1q, early complement deficiency. Tracks gene on chromosomes 3. Gene on X chromosome, Klinefelter syndrome has an increased risk. C2, C3 deficiency, HLA, DR2 and DR4. Environmental factors increase estrogen, OCPs, HRP, Epstein-Barr virus, ultraviolet B. These all are another environmental factor. Pathogenesis, effective clearance of apoptotic necrotosis debris, innate immune system, activation of interferon, IFN, uh, alpha, interleukin 4, TH2. These all are immune complex deposition, type 3 HS reaction in vessels wall, synovium, glomeruli. Vessels walls vasculitis, synovium, synovitis, glomeruli, glomerulonephritis. So ultimately, it is said to be that said that the SLE is a type of autoimmune condition, or it is a type of disease which is most commonly coming from the kidney involvement. Only kidney is responsible for your disease. So we move further, then antibody, nuclear antibody ANA, SLE 97% positive, Sjogren syndrome 85%, plus least positivity among the CTD. Note condition with 100% NA positivity, drug induced lupus erythematosus, type 1 autoimmune hepatitis, mixed connective tissue disorder. ANA testing, ANA testing, screening test for connective tissue disorder. Method for indirect immunofluorescent using a F2 cell line. Positive titer more than 1 by 80. Pattern. What are the pattern? Now it is a tablet form in which the pattern will be explained. So homogeneous, dense, fine speckled, coarse speckled, nucleolar cytoplasmic. Antibody will be homogeneous में anti-DS DNA, anti-histone. So डीएनएस में specific disease will be SLE. Anti-stone में drug induced lupus. Dense fine speckled rules out CTD, connective tissue disorder. Fine speckled में anti-RO और SSA, SSB, Sjogren syndrome will be done. Coarse speckled anti-Smith SLE will be a winner. Anti-UIRNP mixed connective tissue disorder. Nucleolar anti-PMSCL70. Systemic sclerosis, dermatomyositis, overlap syndrome. Cytoplasmic anti-JOH, JO1, polymyositis, dermomyositis. These all are here. ANA negative SLE 3% cases, ANA RO SSA anti LA LA SSD plus ANA positive turn in a ANA anti-nuclear antigen plus patient. So very vast thing, very but very important. So guys, now anti the DS DNA and 3 anti-Smith. Specifically for SLE, anti-Smith is more than anti-DS DNA. Anti-DS DNA is more clinically important. Titers measures by ELISA correlate with risk of nephritis and vasculitis. Anti-RO by SSA, this is the fourth type of antibodies. And anti-LA SSB, these are fifth type. Then now what is this indicating? What the indication by the this antibody will be takes place. So guys, you can see that indication secondary Sjogren syndrome if positive in pregnancy, neonatal lupus with complete heart block, associated with a better prognosis and decreased risk of nephritis, vasculitis, associated with the subacute cutaneous lupus, associated with the shrinking of lung syndrome. Very important for the diagnosis of this antibody. Anti-phospholipid seen in a one third of the SLE patient. Okay, anti-RBC, warm antibody IgG in autoimmune hemolytic anemia, anti-platelet ITP in test idiopathic thrombocytopenia purpura. Now, 9 is the anti-glutamate, also called as anti-neuronal. So these are most common antibodies of CNS lupus. Most common manifestation of CNS lupus, congestive dysfunction. Now, these are 10 number anti-ribosomal P, psychosis and depression in CNS lupus. Factor correlating with the disease activating of SLE, anti-DS, DNA titers, C4 raised, ERS and decreasing CRP. So, guys, note one thing like to discuss what is you have to note factor correlating with the disease activity on SLE, anti-DS and DNA titers decrease C3 and C4 rise. I have told you that note one thing overlap syndrome presence of features of one third of the CTD corrective tissue disorder. So SLE, Sjogren, poliomyositis, dermatomyositis, systemic sclerosis, rheumatic arthritis, these all are very important and very vast disease of the rheumatology. So we have to learn this all by making this uh, proper method of learning, not in a one sitting. You have to revision these videos or these important topics again and again. Then we have to command all this. Then we definitely achieve a good knowledge in this. So guys, mixed connective tissue disorder, the overlap syndrome, anti-UIRNP positive or 100% anti-nuclear antigen positive. Diagnostic criteria for SLE is SLICC. What are the clinical features? Now, what are the clinical features of systemic lupus erythematosus? Musculoskeletal manifestation, chronic inflammatory bilateral symmetrical polyarthritis of small joint in the upper limb, Jacquard arthropathy, non-erosive plus deforming arthritis. Okay. Musculocutaneous manifestation. You can see this face, malar butterfly rash will be seen in this patient. You can see this the rash is a butterfly shaped rash. Photosensitive, erythematous, scaling, on scaring, associated with a non-scaring alopecia, associated with a hard palate ulcer, spare on nasolabial fold, non-pregnant. So Hence, it is very important to look for this such kind of a patient in which this cheek entire, you can see, malar type of rash will be formed. Now we move further. So you can see here subacute and cutaneous lupus erythematosus (SCLE), annular most common, or psoriatism (SCLE). You can see this, the highly photosensitive, non-scaring, also with the anti-ROLA, ROLA, also with the HLA-DR3, decreased risk of nephritis and vasculitis, spared with the mid-facial region. So these all are subacute cutaneous lupus erythematosus (SCLE). Now chronic cont- continuous cutaneous lupus erythematosus (CCLE), discoid rash. Most common. You can see this video, this photo of patient, how he has a chronic suffering from the disease. Chronically, he has a suffering from such kind of you can see this here here. So chronically, these are affected part. So chronic cutaneous lupus erythematosus discoid velar rash is the most commonly affecting. 5% patient with the discoid rash have SLE. 20% with the SLE have discoid rash. Seen in the face, scalp, neck. Circular erythematosus plus dermal atrophy plus follicular plugging. Pre-malignant lesion of small cell carcinoma will be also named. Also with the scarring alopecia, carpet track sign will be also seen in this. Clinical CNS manifestation, small fiber neuropathy plus axial skeletal spare. Ocular manifestation, secondary Sjogren syndrome, most common absence of uveitis. Hematological manifestation, anemia of chronic disease, warm antibody AIHA. Leukopenia, thrombocytopenia, secondary ITP, risk of BCL, plus lung manifestation. So, what is lung manifestation? Lung manifestation: pleuritis plus effusion, exudative effusion with normal sugar, diffuse alveolar hemorrhage, marker of high disease activity. What are the serious manifestations? Cardiac, pericarditis without tamponade, mitral regurgitation, Libman, sex, endocarditis. These all are the cardiac manifestation. Valvular vascular में high risk of acute coronary syndrome in the 5 to 10 years. Vasculitis में immune complex mediated small vessels vasculitis, leukocytoclastic vasculitis. GI and CNS vasculitis dangerous, and renal manifestation about that is minimal mesangial proliferative. These all are no treatment required. Focal, no. Diffuse, most common and most dangerous form of immunofluorescent full house effect of IgG, IgM, IgA, CI1, C3. Electron microscopy, hematoxylin bodies of cross. Treatment aggressive immunosuppression, but membranous refractory to steroid therapy. Treatment of mycophenolate, mofetyl plus calcineurin inhibitors. Low risk of CKD. Advanced sclerotic. Treatment now, first priority is the treatment. Ultimately, we are learning any topic, and without treatment it will be a remain unclear, because to treat a disease is very important. So guys, SLE is very important. So we have to treat it very important. Mild cases or constitutional symptoms या mild arthritis या rash या moderate SLE, oral steroids plus hydrochloroquine plus methotrexate will be one of the drug of choice. For oral steroids, if arthritis positive, belimumab will be preferred. Note, belimumab is a B lymphocyte stimulator inhibitor. ठीक है, सीवियर एसएलई में व्हाट विल बी मेजर ऑर्गन इन्वॉल्वमेंट या लाइफ थ्रेटनिंग डिजीज. IV methyl prednisolone will be dropped. Then oral methyl prednisolone plus IV cyclophosphamide or oral mycophenolate mofetyl. Reassess after 3 months. Good response. 3 years of maintenance therapy with low dose of steroids with MMF and azathioprine. Poor response, change in cyclophosphamide to MMFA or vice versa. No response by end of 3 months, 6 months, then resistance to lupus. Our aim is to now to do rituximab will be given. Indication for the plasmapheresis in SLE will be CNS vasculitis or diffuse alveolar hemorrhage. So, guys, till now we have completed the disease that is systemic lupus erythematosus. Now, don't worry, we will continue this session with another part. So, spondyloarthritis, HLA-B27 positive, RF negative, sacroiliitis positive. Most common extra-articular manifestation asymmetrical, alternating, acute, anterior uveitis. Now here the anterior uveitis will be seen. Before that anterior uveitis was not seen. There will be episcleritis in the rheumatic heart disease, rheumatic arthritis. But here we are talking about the spondyloarthritis and spondyloarthritis where the anterior uveitis will be seen. Okay, so remember this point very carefully. Don't be go in hurry. Okay. Central pathology, cytokines, TNF alpha. Age rate less than 40 years. Males is more common than females. Types. What are the types now? Guys, axial prominent type, peripheral prominent type. What is axial? Non-radiological spondyloarthritis, radiographic spondyloarthritis, ankylosing spondylitis, peripheral predominant. So reactive arthritis, psoriatic arthritis, IBD arthritis, enteropathy arthritis, juvenile onset spondyloarthritis. These all are the peripheral predominant arthritis. What are the radiological features? Guys, radiological features male female is 3 ratio 1. Male are more affected as compared to female. In late teens, early 20s. Okay. Pathogenicity, calcification of peripheral fiber or annular fibrosis, thin margin and symmetrical syndesmophytes, bony ankylosis, bamboo spine. Bamboo spine, like bamboo spine, will be a definitive feature of spinal arthritis. So, clinical features of onset of symptoms less than 45 years of age. Symptoms duration is more than 3 months. Inflammatory deep lower back pain, lower back pain due to bilateral symmetrical ascending sacroiliitis. Alternating early morning stiffness is more than 30 minutes. Nocturnal awakening due to pain improves with activity. As the person or the patient will be doing some work, some activity, then the patient relief from the pain. So it is a main important part to identify the disease carefully. Most common complication vertebral fracture of C5 C6, enthesitis, Achilles tendonitis, plantar fasciitis, costochondral, a manubrial sternal joint, chest pain, root joint involvement, hip and shoulder joint arthritis, root joint involvement, extra-articular involvement, uveitis, lung, cardiac, extra-articular involvement is also important. So for lung, bilateral upper lobe fibrosis, for cardiac, aortic regurgitation, for renal secondary AGA nephropathy, for osteoporosis. So clinical test we will do in this. That is modified sober test, cover test. This is a one diagrammatic review. I will focus this sober test on orthopedic video, but we are not reading it now orthopedic. We are reading of medicine, so we have to focus at that much only, which were given at this place only. So as now we have reached the investigation of the disease. So scoliosis, bone erosion, Romanocyte, bone fusion, ankylosis, bamboo spine दिखेगी, square wave vertebrae, see, secondary sclerosis, shiny corners sign will be seen in this. Interspinous ligaments calcification, dagger sign, anophyseal joints capsule calcification, trolley track sign. MRI will be done and STIR sequelae is to detect sacroiliitis. Now I am discussing about the non-graphic spondyloarthritis. Symptoms present MRI scolitis, sacroiliitis, HLA-B27 positive, X-ray normal, 5 to 10 patients will developing radiographical spondyloarthritis after 5 to 10 weeks. Treatment of radiographic, non-radiographic spondyloarthritis, NSAIDs, physiology, physiotherapy. So for NSAIDs, indomethacin reverses the progression of the disease. For physiotherapy and TNF alpha inhibitors, interleukin 17 inhibitors, secuni, secukinumab will be a interleukin 17 alpha will be preferring this treatment for the spondyloarthritis. So first priority is to do endomethacin, that is NSAIDs. Second, we will go for the physiotherapy. Then we will go for the TNF alpha inhibitors. Then we go for the interleukin 17 inhibitors for secuni. Note: diffuse idiopathic skeletal hyperostosis (DIS). See ligamentous calcification, flowing candle wax appearance, intervertebral disc space preserved, no sacroiliitis. So reactive arthritis occur in a 2 to 4 week post-infection. Yes. Now, reactive arthritis is also post-infection. Genitourinary tract, gastrointestinal tract, upper respiratory tract. These all are the so infection of genitourinary tract. Chlamydia trachomatis is most common worldwide, and male female is a 9%. Gastrointestinal में Shigella flexneri is most common in India, 1:1. Upper respiratory tract, beta hemolytic streptococcus, chlamydia pneumoniae. This is another type of. Note that Neisseria and E. coli do not cause any reactive arthritis. So this is very good point. SLE27 positive indicates risk of chronic reactive arthritis seen in 15 to 20%. Reactive arthritis, acute onset plus sterile or non-virulent. So guys, I am discussing about the features. Peripheral predominant spondyloarthritis, asymmetrical, lower limb is more than upper limb. Additive, painful oligoarthritis. Axial arthritis, 30% cases, asymmetrical sacroiliitis, thick and non-marginal, coarse, full fluffy, asymmetrical syndesmophytes, enthesitis, dactylitis, sausage digits, मैक्यूलम mucocutaneous manifestation में oral ulcer होगा, keratodermo, regia, Cincinnati, balanitis, extra-articular manifestation, aortic regurgitation. So and now the treatment. What are the treatments? So again, that the drug NSAIDs, indomethacin will be given. Sulfasalazine is used for the chronic reactive arthritis. See the blenoregica. Yes, clearly seen the here's a sign. So it is a circinate, balantis. These are dactylitis. So here you can zoom on this. So here ulcer formation takes place at the foreskin of the penis. So the disease is that much reactive. Arthritis is supposed to be cured as early as possible for the patient. For IBD arthritis, Crohn's disease is more than ulcerative colitis. Irritable bowel disease, due to which male-female ratio is equal, no difference between male and female. Peripheral predominant arthritis seen in 25% cases. Ankylosing spondylitis like arthritis, HLA-B27 seen in the 10% cases. So seen in the 10% cases. But what are the types of the IBD? So type 1, type 2. Large joint, knee, predominant migratory, asymmetrical pauci-articular arthritis correlates with the bowel disease activity, self-limiting. Automatic, the disease will be self-limiting by period of time. Okay. But in a type 2, small joint, predominant, migratory, aggressive, polyarticular arthritis plus uveitis does not correlate with the bowel disease activity. Drug of choice is TNF alpha inhibitors. So psoriatic arthritis, male female is equal. Psoriatic arthritis. Now it is a psoriasis, which is a disease which is responsible for the arthritis. So remember this very carefully. So again, back to it. Clearly listen this topic properly. Psoriatic arthritis developing after 40 years of age. HLA CWC 06 to 02 positive. Means there will be a 60-20-20 ratio or rule, where the 60% developing psoriasis followed by arthritis, 20% developing psoriasis and arthritis together, 20% developing arthritis followed by psoriasis. So 60-20-20 ratio here we will discuss. Features. What are the features? Yes, I will discuss. First, articular manifestation. Peripheral predominant arthritis commonly seen in the plaque psoriasis. ठीक है. Pustular psoriasis, severe destruction of arthritis seen in HIV patient. You can see the arthritis multilens here. The shape of the fingers you can see enthesitis, dactylitis, arthritis multilens. These all are features of the articular manifestation. Extra-articular, we will talk about extra-articular. Nail changes. Here the pitting, no, nail pitting will be takes place. You can see the nail pitting will be takes place in this. Now, most commonly. Another will be on kylos, onycholysis. Onycholysis will be here seen in this. Oil drop sign. One is oil drop sign will be seen. Yellowish nail margin, horizontal ridging, chronic bilateral posterior uveitis, aortic regurgitation. These all are features of the nail changes in this classification of psoriatic arthritis. What are the classes? Symmetrical polyarthritis, most common. Asymmetrical oligoarthritis, axial arthropathy, cervical spine involvement positive, thick non-marginal, asymmetrical course, fluffy syndesmophytes positive. Pure DIP arthritis, X-ray finding. What are the X-ray finding of the arthritis? Now, pure distal interphalangeal arthritis. X-ray finding, ray pattern appearance, ray pattern characteristics by involvement of DIP, PIP, MCP. मतलब कि डिस्टल इंटरफेरेंजियल, प्रॉक्सिमल इंटरफेरेंजियल, मेटाकार्पोफेरेंजियल, मार्जिनल इरोजन विद एडजेसेंट बॉडी प्रोलिफरेशन, ठीक है, विस्करिंग विस्करिंग विल बी इन्वॉल्व, पेंसिलिन कप डिफॉर्मिटी, ivory phalanx, arthritis multilens. Treatment first line TNF alpha inhibitors, second line methotrexate, others में interleukin 17 inhibitors, secukinumab, interleukin 12 and 23 inhibitors में utekinumab, JAK inhibitors में tofacitinib, baricitinib. These all are the these all are the features of PDE4 inhibitors, apremilast. These are the features of the arthritis. Now we will with the this disease. Here we will discuss these four in a common way or common topic. That is features of ankylosing spondylitis, reactive arthritis, interstitial bowel disease, and psoriatic arthritis. Features. First, I will go for this. So bilateral sarco लाइटिस थीन मार्जिनल सिमेट्रिकल सिंडेस्मोफाइट्स दिखते हैं. रिएक्टिव में एसिमेट्रिकल इन्वॉल्वमेंट थिक नॉन मार्जिनल एसिमेट्रिकल सिंडेस्मोफाइट्स दिखते हैं. बायलेटरल आईबीडी में बायलेटरल सैक्रोलाइट्स थीन मार्जिन सिमेट्रिकल सिंडेस्मोफाइट्स दिखते हैं. सोरियाटिक आर्थराइटिस में एसिमेट्रिकल इन्वॉल्वमेंट थिक नॉन मार्जिनल एसिमेट्रिकल सिंडेस्मोफाइट्स दिखते हैं. एंथीसाइटिस पॉजिटिव पॉजिटिव नेगेटिव पॉजिटिव. All are positive, only one is negative, that is IBD arthritis. Dactylitis negative, positive, negative, positive. Skin and nail changes will be negative, negative. Yes, nail changes takes place. Now most skin will be affected is reactive arthritis. Here mucocutaneous manifestation, keratoderma, linorrhagica, circinate balanitis will be here. What are the summary? Guys, chronic symmetrical small joint arthritis, rheumatic arthritis, psoriatic arthritis, SLE like arthritis, calcium pyrophosphate deposition tissue, DCPPD, these all are the chronic symmetrical small joint arthritis. What about the acute asymmetrical polyarthritis, reactive arthritis, psoriatic arthritis, mono? These all are acute symmetrical oligoarthritis. I am going to discuss about the monoarthritis, crystal arthritis, NTP joint plus septic arthritis, knee positive. Non-inflammatory arthritis, oligoarthritis, asymptomatic CPPD, calcium oxalate crystals disease, calcium hydroxyapatite deposition disease. Inflammatory non-erosion arthritis, SLE like arthritis, erosive arthritis, psoriatic arthritis, peripheral spondyloarthritis, chronic taphogenous gout. So guys, 54 minutes has been passed and you are excellent and If you are watching this video till now, that shows that your courage of learning and skills. I hope I have to. I think till here we have done very excellent thing for you now. Yeah, I have to stop this journey to these minutes, and we will be continue after a few minutes or a few hours of time. And thank you for watching this video, and I hope you like this video, and there will be two like, and thank you for this, and I hope this pattern of learning by you and me will be definitely grow, and thank you for watching. Thank you. Jai Sri Ram, Hare Krishna, Hare Krishna, Krishna Krishna, Hare Hare, Hare Rama, Ram Ram, Radhe Radhe.